changes your brain because it's going straight to your central nervous system. And so that nicotine just becomes, it's an addiction. So you're really dealing with an addiction problem. And who wouldn't want to help somebody who has an addiction problem? So,
Absolutely.
We need to do better in medicine. And we don't want to see you come to the Mitchell Cancer Institute one day. We'd really rather put ourselves out of business.
That's right. That's exactly
Not
right.
that we would.
Cancer is just something that we all have to recognize, acknowledge, cope with, live with, struggle with, rage upon, crush, and even thrive with. This show is more than knowing and fighting or beating cancer. It's more than just relaying science, hope, and technology. Together, our purpose is to demystify cancer, take away as much fear out of the diagnosis, treatment, and process as we can, defeat its grip on our lives. This is The Cancering Show. Hi, everyone. Welcome to the show. November is Lung Cancer Awareness Month, and I am very excited to shine a spotlight on this important diagnosis and all the things that we can do for prevention. We have today in the studio Susan Crutchfield, a nurse and now senior manager of community and physician outreach at the USA Health Mitchell Cancer Institute. Susan has been instrumental in getting a lot of our smoking cessation and lung cancer awareness events off the ground, and we're super excited to have her here to tell you more about those. Susan, welcome to the show.
Thanks for having me.
So we know that lung cancer is a leading cause of death worldwide. Chances are everybody who's listening has known someone who has had lung cancer or passed away from lung cancer. Do you find that true in your outreach work?
Oh, absolutely. Absolutely. And it really is that, in terms of Americans, most people don't think about it this way, but, back in the 40s and 50s, almost half the country smoked or used tobacco in some form, which is kind of shocking. We don't think about it. It's been coming down since then. And so we're more used to that. But there were a lot of tobacco users back in the day.
Yeah. And I know you saw this as a nurse. We see it in all the old pictures from the departments, doctors smoking in the doctor's lounge.
Absolutely.
And teachers smoking in
Nurses.
the teacher's lounge.
Yep.
Yes, absolutely. It's crazy to think about that time. But you're right. Those are the same people we're now treating who have aged into cancer diagnosis. So, Susan, tell us about kind of your role at MCI and how you got interested in lung cancer prevention specifically.
So, first of all, I'll tell you, my role is totally prevention, oriented, and I don't do anything in terms of the clinical practice or whatever. So I'm just totally prevention oriented, but I have a passion for it probably from a very early age, especially about tobacco. So I love this topic. I'm glad we're talking about it because my father was a smoker, and he was like everybody. He wasn't a smoker until he went off to the Korean War, and he came back a smoker because GIs, one of our primary ways, and even we were giving out cigarettes. It was like a way to kind of have groups of people together and calm them down and, make them be cohesive. They had commonalities and things, and they were just biding their time. So anyway, he came back a smoker, and he luckily quit when I was younger. But I will never forget when we were all in college, my siblings, I have 3 siblings, and we all came home from college, and we had decided to paint our family den. It was a tiny little, houses were much smaller, a little ranch-style house with, bathrooms that are the size of closets now, really. And we had a very small little den that we were all in, and it was just sort of had that pine paneling around it, and it was so depressing in a way. And we thought, what we can do is to put a better color. And my mother was excited about this, and so we were going to do this as we all came home for a weekend and decided to do it. So anyway, we take this on as a project, and we started washing down the walls to be able to just, because we were like, when the walls feel sticky almost. We never thought about the fact that my father smoked. We're like, and we had these drab beige draperies that are on the wall that my mother had made, these little cafe curtain rod things or whatever. Anyway, long story short, as we began to wash down the walls, nicotine started rolling off the wall. We finally figured out what it was. We were going
my gosh.
This is amazing. It was not even close to the same color because my dad sat in that little den and smoked as we all sat around watching television or whatever, and he was smoking cigarettes and then cigars after that. Anyway, it was just something that was so impactful for me, and I thought, oh my goodness, I have been getting secondhand smoke, and here I was at that point getting into nursing school and just thinking all the repercussions of that. And I thought, this is really terrible because it's such an innocent beginning and nobody intends for it to be. He luckily started having a few health issues, and they talked to him about tobacco cessation. So I think it is so important for doctors to have that conversation, nurses to have that conversation, anybody that cares about their patients to have that conversation with them about tobacco.
I think that's so important that you say that. We have so many people who think, well, everybody knows that smoking's bad. So if they're choosing to smoke, then why bother telling them? By the very fact that they are a smoker, they're kind of automatically resistant. But there's really great data that says that a doctor or a nurse mentioning it, in particular, linking it to a health problem, just like you said, is so impactful. So I have a story to tell about my mother-in-law, Barbara. Shout out to you. I know Bill listens regularly, and they're both cancer survivors. But I met my mother-in-law as a patient before I met my husband. That's a whole nother story. And for you regular listeners, if you ever want to hear it, write in and we'll have an episode with my father and mother-in-law. They're fantastic people. But I was the doctor on call discharging my mother-in-law, Barbara, and she had a cancer diagnosis and was about to need to go home on oxygen because she was a chronic smoker. And me just linking the fact that the need for oxygen at home after surgery was because she was a smoker was enough for her to quit permanently and never pick them up again. And she did not actually need to go home on oxygen. She managed to, walk enough and take those deep breaths to get off of it. But it was that moment when she decided she would not smoke again. So it's so impactful for a doctor to say it and to link it to a health problem or a need to make a change.
Yeah, absolutely. And I think that me being a nurse, obviously, I certainly saw it with patients coming in, but I was more in a primary care setting. But working in oncology, it's amazing when people, whenever they get that diagnosis, they so often will immediately, say, okay, I'm done with the cigarettes or I'm done with the, whatever form of tobacco they're using. But that's not what we really, we would love for them to have had that conversation with their primary care doctor long before.
Absolutely.
Because it's very hard when you have a cancer diagnosis. That's a very high stress moment. Mm-hmm. And so it's very hard to try to quit actually then. They might quit for a few weeks, but then they so often go back to it. Absolutely. And there's so many reasons in cancer. You can speak to that, wound healing, their chemotherapy being more effective.
Absolutely. Radiation.
Correct. Yeah. Radiation, all of it, that comes into it. And so you want to give them, you just would love for them to have the opportunity to have stopped tobacco earlier.
Absolutely.
And they need that encouragement. I mean, I always tell people when I do a lot of benefits fairs for counties, cities. I was just at the USA Benefits Fair this morning. And people who are tobacco users, if come up to your table, they see the materials on there, they don't mind your mentioning it. They honestly don't. If you do it in a very caring way. And I always say, we're not here to beat you up at all. What we're here to do is to tell you that we care about you. We care about you as an employee, but even at any place. And we don't want to see you come to the Mitchell Cancer Institute one day. We'd really rather put ourselves out of business.
That's right. That's exactly
Not
right.
That we would, but, it's something where we want to help you where we can. So let's diminish your risk, or let's talk about it. I want you to take these materials with you, and then I want you to think about it and, see if you need to get help. And that's the other thing. It so frustrates me that so many people don't realize that there really are many things that we can do now,
right.
In terms of medications that we can give. We realize that the type of, therapies that are out there, we can give those medications to patients and then give them an additional medication for breakthrough and that kind of thing. So, and it's not a one-size-fits-all. Somebody says, well, it didn't, they prescribed varenicline for me and it didn't work. It made me feel this or that. There are alternatives and they can give it to you and let your physician adjust that.
Absolutely. I love that you mentioned that. And I'm going to go back to a couple of points. One, that there's no judgment here. When I tell patients, and I too grew up with a parent who was a smoker, it was the hardest thing she's ever done. And I know that nicotine is the most addictive substance on the planet. And, right up there with sugar and caffeine. And I love my cookies and my Diet Coke. So I too get it, how hard it is to kick any one of those three very, very addictive substances. And Two, that there is so many ways that we can help people, that, cold turkey is not the only way anymore, and that is very hard. And there's lots of resources, your doctor, your medical team, even online resources, the Quit line, so many options available to people to give you that support, that non-judgmental assistance, and even, as you said, kind of medications and things like that for quitting assistance.
Absolutely. And I think that, 90+% of people start before age 19. Yeah. They usually average age is like 15 years of age. And so when you think that's really a child still, and it changes your brain, it changes all sorts of, things that make it very tough for you because it's going straight to your central nervous system. And so that nicotine just becomes, it's an addiction. So you're really dealing with an addiction problem. And who wouldn't want to help somebody who has an addiction problem? So,
Absolutely.
We need to do better in medicine.
Yeah. And as you said, kind of start earlier, the sooner that you can quit, the better. I always tell my patients 3 things. 1 is the hardest thing you're ever going to do. 2, you're still going to want a cigarette every day. You just get up that morning and choose not to have one. And as you said, that is in keeping with most of the addictions that we talk about. And 3, you really have to tune into your why and to, kind of have something really strong that you're holding on to. For my mom, she quit at 60, and her why was to live long enough to see her grandchildren. She unfortunately had 2 children who didn't marry till 35 and didn't have kids till close to 40. And so she had to wait a long time for those grandkids, and she was older than she had wanted to be. And so she really wanted to make sure that she was healthy enough to run after her grandkids. And I tell my patients this all the time, that at the time she joked and said that if she lived to 80, she was taking it up again, that this was just a temporary pause in her smoking. Now, I will tell you, she's 76 and still cigarette free. The other thing I think that was a big motivator, you mentioned kind of the cleaning house and renovating and, those changes that they've made to laws like needing to smoke outside, but definitely for families, if you are looking for a motivation, kind of recovering your favorite chair or repainting the room can be motivation enough to say, okay, I'm not going to smoke in this room anymore. I'm not going to smoke in the house anymore. And that one step leads to another. So tell us, when you think about going out to these fairs and stuff in November, what's the real message other than tobacco cessation that you want people to know about lung cancer prevention? Okay,
so one thing that I think absolutely has to be addressed, or whatever that I'm seeing more and more of it, is vaping. Mm-hmm. And that people think that that's a fantastic alternative. And in fact, it's really pretty scary. And of course, vaping hasn't been around as long. And because we're in science, you can't condemn something that you're saying, well, is the science really out there to substantiate this? But in fact, and I will credit Dr. Robin Mockett, who's in the nursing school at South, who sent me an article recently that there was a large study done in Korea. Actually. So that's the first large study that they've done where they actually could show a connection between lung cancer itself and vaping. Yeah. But I'm really scared by that, because what is happening with the vaping is that it's showing that people aren't necessarily diminishing their smoking. Mm-hmm. What they're doing is dual using, that they're actually taking that vape, and because vapes can have such a higher nicotine content, it's actually making them more addicted. Right. And at places that they would have gone outside, you're exactly right, not instead of going out to smoke, they're able to just have a little something in their pocket, a jewel or some other, type of device, and then just take a hit from that. But what they're doing is keeping that constant nicotine. Right. So that's one of the toughest messages that I'm out there trying to talk to people about, is especially that, because I'm seeing it so much in young people. Yeah. And that's probably where my heart is the younger people. Yes, I think older people should quit as well. But when I see young people that they're going to have a lifetime of it, right, I just think it breaks my heart. And I really see it as a social justice issue too, because what statistics bear out as well is that you may have all children trying it, but those who may go on to have a college education and so forth, they're able to kick it more than those from the lower socioeconomic yes. backgrounds. Mm-hmm. And so it's especially awful because you know what their lifetime is going to be, and they're the people who can afford it the least, right. And who will probably may struggle with health insurance,
and may have a higher risk.
And have higher risk. All these things combined. So it really, to me, it carries that that component, as well. That it's a social justice issue, and we should really try our best, especially with young people, to not let this happen to them.
Absolutely. To circle back to the vape, one of the things that I mentioned to my patients that they're not aware of, a lot of people look at the vape and say, okay, well, I've gone from 743 carcinogens down to 1 carcinogen. But we do know, as you've said from that study, that nicotine itself is a carcinogen. A lot of people used to argue that, all the other things that were in the smoke were the cancer-causing things and nicotine was not. But actually, in fact, nicotine is a cancer-causing substance, and we know that. And 2, the amount of nicotine in a single cartridge is not equivalent to a cigarette. It's equivalent to a carton of cigarettes. And it's so addicting because the higher the dose, the faster it reaches your bloodstream. We know that that's more addictive. And the thing that scares me so much, I saw in the news, they did a program of teachers. They had a whole set in a classroom with various vape objects, and the teachers were to go and try to find the vape objects. And they missed the ones that looked like a highlighter, the ones that looked like an eraser, and the hoodie that the 2 ties were vape tubing.
Oh, wow.
Isn't that crazy?
That is so crazy.
So there are so many ways that it's specifically targeted to young people. The last thing I will say when we're talking about, talking to maybe someone in your family who is vaping or who has considered vaping, is we really need people to avoid any of the flavors. And a lot of people in this industry of cancer prevention really believe that making all these unique flavors is really trying to get young people to smoke, because obviously it doesn't taste good. But the flavors themselves are causing so much toxicity in the lung. There are young people who need double lung transplants because of the inflammatory response to these flavor additives that are so terrible for your lungs.
Wow, that's awful.
So,
I know, we thought it was just menthol that was the bad thing.
Right. Oh, my
the bad actor.
Right.
We have so many more. Tobacco companies are very clever. That's all I will say.
Yep.
It's like they watch the rate go down and, they're going, well, we'll come out with something.
Right. It's a very important point that there is this kind of targeting to young people. And so you are out there combating it. Tell us about the Great American Smokeout.
Okay, so that is directly targeted at South Alabama students because obviously that is an audience that we so want to reach, our own students. And we've held it for the last few years. We've had different things that we've done at the Great American Smokeout. This year I'm trying very hard to get more students engaged so that they can do more peer-to-peer interaction. So I appreciated one of the fellows with you coming out and speaking to them. That was very effective. Went out for on campus and did a talk with a lot of the leadership for some of the student organizations. And I think we have a lot of engagement, so we'll see. I'm crossing my fingers that maybe they'll be out there with us. But that's always the third Thursday of the month. It is a national event that's conducted by the American Cancer Society. We have always tried to participate in it, but in recent years we've really focused on, I think, trying to get our younger people, or I have, because I think they're the ones that we really need to reach. So we'll see.
Yeah.
So it'll be that same third Thursday on campus. And
awesome. I know it'll be a great turnout. And I think one of the greatest things is looking at the tent at the end of the day and all those pledge cards. And remind me, is that pledging to quit, pledging not to start, pledging to talk to somebody about quitting?
Exactly. It's all of those things. And we don't make them say, okay. And the other thing you'll find, and oh gosh, is that students are so quick if they're not a tobacco user to say, no, I'm not. But if they are a tobacco user, they may just say, when you ask them a question, or whatever, they don't necessarily deny it. They just kind of are evasive about whatever. So, or sometimes they'll say, I like the information. You don't really know if it's because for them or a loved one or something, but they can do it on behalf of somebody that they know, that they intend to share the information with or something. So they're making that pledge to, it's supposed to be quitting for one day is what it's supposed to be. But that's the national, that's what the ACS has it for. It's just for one day to try to quit. But we allow them to sign a pledge card on behalf of somebody to share that information on this day or something too. So, yep.
And I think that that is so powerful. One of the things that I tell my patients as well is that the average successful quitter tried to quit 6 or 7 times before that. And so we always say, well, if you quit and fail, you're just one step closer to the time that you will quit and be successful. And it's true. It's true for smoking cessation. It's true for weight loss, that the only people who truly fail are the people who quit trying.
Totally agree with that. And that is exactly, like I said, that's reinforced from the table as I sit there at these benefits fairs, at these, even industries have these, benefits fairs as well. And it's helping them to what these fairs are. And people have asked me that in the past, what these do. And they actually are, have dual uses, but they're trying to show them resources in the area that if they do get a diagnosis, who would they contact, what would be next steps and who would they choose to go see and that kind of thing. So it's helping them to recognize that, but it's also encouraging them to do prevention type work, that's there. But I get that all the time where, people will ask about tobacco and say, well, I've failed before. I just don't think I can. Or they will say, I quit for 2 years, but then I came back to it. It doesn't matter how many times you've done it. It doesn't mean that now isn't the time, and now isn't the time that you'll stay off of it. And a lot of them do think cold turkey is still the only alternative, and it's not. So let people help you.
Absolutely. I think all of those are great messages. I want to move briefly from kind of tobacco cessation as a means of cancer prevention, which is incredibly important. And as we said, just to highlight this again, it's important for all of our types of cancer. Anyone who's smoking and has cancer or a health problem related to smoking, quitting works great for everybody. But let's talk about preventing lung cancer in people who have a history of smoking. Talk to us about what is that recommendation?
Well, currently, and we work all the time, and I say that's like, the low-hanging fruit cancers, or whatever, which are breast, cervical, colon, prostate, skin. That's what we traditionally worked in because those were all things that you could screen for. They're screening tests, things that people can actually do themselves to help diminish their risk. And we've added lung only in recent years because there's now low-dose CT screening. So that is something that we can talk to them about. And what the criteria they currently say, and understand, you can go on a website and you can look, and one recommendation might come from the USPSTF, one might come from the American Cancer Society, and they can differ. But what we usually say at Mitchell Cancer Institute, and we sort of, came up with what we agreed with most out of those recommendations, is that you need to be 50 to 80 years of age, that you need to have a smoking history, what they call a 20-pack year smoking history. So that's a pack a day for 20 years, or the equivalent would be 2 packs a day for 10 years, and then you have either quit in the past 15 years or you have, continued to smoke within that 15-year window. So that's the biggest recommendation. But, you're also looking at that's just criteria for why should you get low-dose CT screening. Right. But it doesn't mean if you're symptomatic of something, if you've got a cough that's worsening, if you say, well, occasionally I cough up blood, and you go, and that just happens, that's just this time of the year. Don't ever, think that symptoms don't matter, or that you've been having this for a while. Don't go get it checked, because the terrible thing about lung cancer is that it, gets diagnosed so late, so often. Mm-hmm. So that's why low-dose CT screening is recommended, and we hope people take advantage. When it first came out, everybody thought with the introduction of it that a lot of people would jump on board. They haven't. We don't know what the reluctance is about, but part of it is that we think it's a lack of awareness, which is why we're doing things like this.
Absolutely. So for those of you out there who meet those criteria, we recommend you talk to your doctor about getting a low-dose CT scan yearly until those criteria are no longer met, meaning either until you're 80, until you've quit for 15 years. And so, the goal is to find early lung cancers when they are still operable. And I will tell you, my best friend's mom was diagnosed with lifelong smoker, diagnosed at a stage 1 with lung cancer, had it surgically removed, had chemotherapy, and is 5 years cancer-free. So those stories do exist now that we have this option for low-dose CT scanning. And it's important to remember that it is low dose, so that that's why it's so important to mention those symptoms, as Susan talked about, because for symptomatic CT scans, that's a different scan than for patients who are asymptomatic. We're using it for screening because we want you to be able to get 30 years of yearly CT scans, and that can be dangerous if it is the high dose scan every year. So you really want to have that conversation with your doctor and make sure you're on the list to get those scans yearly. And last, we want to talk briefly about the fact that there is a group of lung cancer patients, 10 to 20%, who were never smokers. And, we don't want them to think that we don't see them when it comes to November. We want November to be about lung cancer awareness for all patients and for everybody out there. So what do you say to those folks that are wondering if there's a risk for lung cancer maybe in their family, or because, as you and I were exposed to secondhand smoke as children, or maybe even on the job?
So I think that's absolutely one of the saddest things, because those types of cancers seem to be very, very aggressive. And it really breaks my heart. I actually happen to know a young man from the community that I live in, which is in Baldwin County, that, he was in his very early 30s. And it was so tragic because it was misdiagnosed early on. And understandably, he had never been a smoker, so they weren't looking for that, and he sadly did pass away from lung cancer. But, I guess my thought is that that's one reason when I say the low-hanging fruit cancers that I talk about is it's been estimated that we could eradicate 60, 70% of cancers if people did their screenings, if they, behavior modification, gave up tobacco, got out and exercised just a little bit, not even knock it out of the ballpark, but just walking, just, things that we would have done in the past, eating a little better, just in little ways. And then we could really devote the dollars to trying to understand these really difficult cancers. And I feel like a non-smoking lung is one of those difficult cancers. We don't fully understand it. We don't understand what causes it. It seems to just hit out of the blue. And I'd love to see our research dollars focusing more on that instead of so much treatment that we're having to give. And I think it would be beneficial to everybody, beneficial for the folks out there. But so I guess that's why I think prevention is such an important thing to work in.
Yeah, absolutely. And I will say, as you mentioned, drugs that we have used for the majority of lung cancers now can be used in some of these more dangerous cancers that are diagnosed in non-smokers. And some of the hope that we have found in lung cancer in general is now applied to these cancers. We have a show coming up that is of a young woman diagnosed with stage 4 lung cancer 6 years ago, who is doing amazing, and thanks to research and a clinical trial and a new drug. So I do think that the more we know, the better off all of the patients are. And there's so much hope to be found in these new kind of targeted drugs with the genetic screening, in immunotherapy, and so many of the newer drugs which we have accomplished and learned about through research.
Right. I think that's fantastic. And I'm so 6 years out. That's amazing. I can't wait to hear. I'll be listening for that podcast.
Awesome.
To hear what she has to say. But yes, I think prevention is it's a very heartfelt thing that to work in. It's a privilege to work in it, because I do think that if you just genuinely care about people, they enjoy hearing that you would really like to like for their well-being, for them to make good choices for themselves, for their family members, and live longer, better lives, which is what we say at USA Health.
I love that. It's a great place to end. Susan, thank you so much for being in the studio today. We will be looking for the Great American Smokeout, a third Thursday in November. And we so appreciate all that you do for USA Health and for the Mobile and Baldwin County area.
Thanks for having me.
And that wraps up this special episode dedicated to Lung Cancer Awareness Month. We hope today's discussion has shed light on the critical importance of prevention, early detection, and the relentless ongoing fight against lung cancer. A heartfelt thank you to Susan Crutchfield for coming into the studio today and sharing her invaluable insights and personal stories. And as always, continuing to work tirelessly in our communities to support awareness and smoking cessation. To our listeners, remember your health is in your hands. Talk to your healthcare provider about the risks of tobacco, exploring available resources to help quit using tobacco, and don't hesitate to ask about those low-dose CT scans for lung cancer screening if you qualify. Let's continue to educate, advocate, and support those on their journey to quit smoking and improve their lives. The Great American Smokeout is just right around the corner. Let's make it a day of positive change. If you found this episode helpful, please share it with your friends and family, and don't forget to subscribe for more empowering stories and expert advice. Until next time, keep cancering and take care of yourself. Thanks again for listening, and don't forget to submit your questions at www.cancering.com. We're here for all of those questions, and we'll get you the answers. This show is brought to you by the University of South Alabama Mitchell Cancer Institute. MCI is a cutting-edge cancer research and patient center built to fight cancer smarter in Mobile and Baldwin County, Alabama. Our researchers and clinicians focus daily on the struggle against cancer, serving a potential catchment population of more than 4.1 million people, with a singular focus of advancing cancer diagnosis, treatment, and prevention throughout the Gulf Coast and beyond, with science, technology, and hope. Want to know more about the Mitchell Cancer Institute? Visit us at usamci.com or search for us on Facebook, Twitter, and Instagram. Mitchell Cancer Institute is a member of USA Health. To learn more about all of our hospitals, clinics, and services, visit usahealthsystem.com.